Well, it seems to me that there are very few of us that have not had family, friends, co-workers that have had the requirement to be in a nursing home. And when they reach that stage, it is often something that's very challenging, and they are often dealing with serious problems that need a level of service in those nursing homes. And a person that has for 11 years been particularly focused in this area, and it's a very important and very technically specialized area, and that is John Daly from the law firm of Daly and Marino from Long Island in Nassau County. It's been our pleasure to work with John on a number of these cases, and I think you will find our face-to-face discussion very much of interest. John, I guess the topic that would make most sense is nursing home negligence. And when you speak about that generally, what laws are you looking at as a practitioner in this field when you think about the nursing home negligence?
Okay, well, John, as you know, our population is getting older, and as time goes by, there are more and more people, unfortunately, whose families have no choice but to have them reside in nursing homes due to the care that they need. And in New York State, we have a very specific set of regulations that governs how residents are to be treated in nursing homes. And it comes under the auspices of the New York State Public Health Law. And if I had to sort of condense the entire law into a brief phrase or sentence, I would say that the law requires that each resident in a nursing home is entitled to care and treatment that rises to whatever level they need to be kept healthy and safe. And the law is designed to make sure that if a nursing home is going to accept the resident into the facility and either take the state's money through Medicaid or the federal government's money through Medicare, that they provide the care that the resident needs.
There seems to me to be two different areas. One is care and the other is safety. Now let's focus on the care. What is the level of care that, let's use an example of someone's mom. So the mom is now gone into the nursing home. What is the level of care that the son and of course the mom would anticipate? How do you evaluate that from a legal perspective?
Okay, so the first thing you want to look at is, was your mom, when she was admitted into the facility, assessed properly? And that means a complete assessment of all of their bodily functions, their ability to ambulate or not ambulate, their ability to care for themselves, whether it's eating or toileting, and you have to make sure that the assessment is accurate. Once the assessment is done, and the New York State law and the federal law requires that both a nurse and a physician do an assessment upon the admission, you want to make sure that the care plan that's put in place to address the resident's needs are being followed. And that means all of the things that person needs to be cared for properly medically, whether it be medication, whether it be physical therapy, or anything they need to treat whatever conditions they're in the nursing home for.
That's the care. Let's talk about the safety aspects.
Okay, so just like with care, there has to be an assessment done to determine whether the resident herself is at risk for either falling or suffering harm as a result of an inability to turn themselves in bed. So the nursing home is required to put for example, fall care plan in place. Their ability to walk, to ambulate, to use the toilet on their own has to be addressed such that they don't attempt to do something on their own and either fall and suffer an injury, or sometimes even worse, fall and hit their head and die.
What is your assessment in dealing in this field as you do day after day about the quality or effectiveness of these assessments as a person is coming into a given nursing home?
Okay, we see some facilities that do a very good job of assessing the residents and do their best to make sure that they cover all the bases with respect to the residents' needs at the assessment once they're in the nursing home. And then there are other facilities, unfortunately, that don't do such a great job. I think the problem that we see over and over again is that many facilities tend to put profits before people. We have to remember that nursing homes are in a business to earn money, and even though some are technically nonprofit, they are really not nonprofit. They're all in the business to make money, and you have to make sure that when you enter into a facility that the staffing is appropriate, and as a family member, you want to ask those questions. You want to ask about the number of aides, for example, there are, how many beds are there, to make sure that they can give your mom the care that she needs.
Generally, it's very interesting you mentioned that, for example, which is so fundamental. Basically, if you're taking your precious mother and you're putting them in the hands of a nursing home, do you find that things like staffing and other care plans are honestly put forward to the individual son, daughter that we're using in the exam?
I want to say yes, and I want to believe that it's true in most cases. However, I think that one of the fundamental issues we see is the fact that many of these nursing homes are not staffed appropriately. And unlike in some other states, New York State does not require a specific level of staffing. For example, the New York State law does not require a specific number of nurses or nurses' aides per shift or per floor, whereas in some states they do. So the law requires them to have what we like to call adequate staffing. Mm-hmm. But adequate is a word that can mean different things to different owners of nursing homes. Sure. And unfortunately, we see too often that the staffing level is too low, particularly with nurses' aides, to care for the high level and the high number of amount of needs that residents have. As an example, if you are immobile as a resident and you're not able to turn yourself in bed, you might require one or sometimes two aides who need to come every 2 hours to shift your position so that you don't develop pressure ulcers or bed sores. And we find, unfortunately, that most facilities do not have an adequate level of staffing.
You mentioned statutory requirements for a nursing home, and I thought that you had mentioned New York State. Are there other federal or other requirements, and is there any distinction between them?
Yes, there is a concomitant series of federal regulations that were passed back in 1986 that govern and regulate care nationally. New York mirrors the federal statutes with some exceptions, I should say. One notable exception is with respect to pressure ulcers or bed sores. Most people are familiar with what these are. They can be very, very dangerous for an elderly person, particularly those who might already have other predisposing diseases. And the New York regulation requires that if the resident gets a bed sore or a pressure ulcer or comes into the facility and it worsens, the facility is responsible for that unless the facility can show that they provided all of the necessary care and treatment to prevent that outcome. And I can tell you that more often than not, when you see a resident with a bed sore, with a new bed sore or a pressure ulcer or a new pressure ulcer or a bed sore that worsens, it's because the staff is not offloading pressure on their body. They're not coming in and turning them frequently enough. And unfortunately, these bed sores develop.
We'll talk about the different kinds of injuries that you experience a lot. We're always interested in our face-to-face discussions on the issue of statute of limitations. What is that with regard to nursing home?
It's an interesting point because oftentimes when you have a situation in a nursing home where you're alleging that the care was substandard, you can have both a medical malpractice cause of action as well as a cause of action under the state public health law. And the courts have ruled that those are distinct causes of action. So for a claim under the New York State public health law, which sounds in general negligence, the statute of limitations is going to be 3 years. Unlike a medical malpractice cause of action, where we have a shorter statute of limitations of 2.5 years. So oftentimes, the attorney handling that case has to analyze very carefully what claims may be related to the public health law and what claims may be solely as a result of a doctor's negligence. Because remember, we do have physicians that are in the nursing home who are rendering care and treatment.
You mentioned 3 years. It's always important, and maybe for our viewers, to clarify, that's 3 years. When does that 3 years normally start?
Again, it's a question that can be interpreted in more than one way. Generally speaking, from the time the person is discharged from the facility, that's when the 3-year clock would start ticking. You don't generally see a continuing treatment doctrine applied to nursing homes. Okay. Whereas in a medical malpractice action, as long as the person is still treating with the doctor, the 2.5-year statute doesn't really start to run. So to be safe, we calendar all of our claims as medical malpractice causes of action at the 2.5-year limit, but for the public health law claims, it would be 3 years from discharge.
The son is having his mom go to our hypothetical nursing home. And what recommendations do you have for that son to be asking about as it relates to the level of care for his mom? Of course, it varies depending upon the condition of the mother here, but what are the things that son should be thinking about?
Okay, so I've developed my own sort of 10-point checklist that we give out to clients and to anyone who's interested or asks. And the first question you want to ask is about staffing. Once you learn how many residents are on a particular floor in the facility, you want to know for each shift, and there's generally 3 shifts that cover the 24-hour period, how many nurses are assigned to the floor? How many aides are assigned to the floor? How often does the doctor come and visit the residents in the nursing home? So staffing really is the first question that has to be asked. And then the only way to really know what's going on is to actually come and visit. And we recommend that family come and visit at different times during the day.
That's a good point.
Come at breakfast time to see how many people need assistance eating and whether your mom is getting the help she needs. Or come at 11 o'clock after breakfast. Is her tray with food still sitting there untouched? Come at dinner time, either before or after, to try to learn whether or not she's eating. Come in the middle of the day and visit the day room. Are the residents engaged in activities? Are they being taken down for therapy? Or are they being warehoused in a large room in front of a television? These are only things you can learn by actually going to the facility and looking.
I think that's a very, very good point that you're making, and that is, I think many times people, well, listen, let's go at 3 in the afternoon to see, and that may be the easiest time for a visit to observe the various times, dinner, breakfast, etc. I think that's an extremely important point. When you talk about mobility, this to me is so important, and it can lend itself into what we're going to talk about, the type of injuries. But when you speak about mobility, obviously you mean the ability of an individual patient to be able to get around. Where are the areas of potential injury to an individual?
Okay, well, there are several. And when I talk about mobility, I'm talking about not only the ability to walk or to ambulate, I'm talking about the ability of the person to actually move themselves when they're in bed or when they're in a wheelchair. Immobility, the inability to move, has and can have serious consequences. Pressure ulcers, bed sores being one, lack of circulation and circulatory problems being another. So when we talk about mobility, we are talking about the ability of the person on their own to be able to move. And it's very important that that be adequately addressed in the care plan. For example, some nursing home residents can not only can they not walk, but they're not able to be moved from place to place without the assistance of a machine. There's a machine known as a Hoyer lift, which is required to lift people who cannot move at all from a bed to a chair. That apparatus needs to be not only operated properly, but it needs the adequate and proper staffing. It needs more than one person. We've seen numerous cases of one staff member trying to operate a Hoyer lift, and it is very unsafe and can have serious consequences. Falls that cause fractured hips, fractured legs, and even more serious injuries such as head traumas, which can end up causing subdural hematomas. And unfortunately, we've had clients die as a result of the nursing home staff not using the equipment properly.
I could certainly see situations where you need more than that one person to be able to move, maybe to get to the bathroom, as the case may be, even to get into a chair. You used an expression called care plan. What is that?
Yeah, that's a term of art. A care plan is the roadmap, the guidelines that the staff at the facility must follow to provide the level of care that the law requires. For example, in the care plan, it's going to discuss whether or not the resident needs assistance eating. It's going to discuss whether or not the resident needs one or two persons to assist them in moving or getting from bed to chair or from bed to someplace else. The care plan is going to be sort of the all-encompassing document that includes all of the instructions for the nursing staff and the nursing assistant staff. The physician has his own set of instructions, his own set of information that he has to follow in order to provide the proper treatment. So the care plan really focuses on the nursing care that the resident needs, and that includes all of what we refer to as ADLs, or activities of daily living, which would be eating, toileting, bathing, things of that nature.
Let's talk about types, classifications of injuries. And you mentioned before about the term that I suspect many people are familiar with, and that is bed sores.
Yes.
How often do they occur? What is your experience? And I have seen, and we've had the good fortune of working with you on a number of cases, and I can recall the pictures are pretty darn graphic.
Yeah.
But tell us about bed sores.
Yeah, I mean, bed sores are, it's a pretty simple premise that I think most of the viewers will understand. We have different parts of our body which are referred to as bony prominences. That means there's less tissue that cover those areas, such as the back, the sacral area, or the hips, places where the bone is close to the exterior or the skin. If unrelieved pressure builds up in that area, for example, if somebody is left sitting in bed or laying in bed for hours and hours at a time and is not moved, then the circulation to those areas of the body is going to be decreased because the pressure that is building from the contact doesn't allow blood flow to that area, which causes tissue to die. It's not getting oxygen, it's not getting nutrients. These, for the most part, are avoidable injuries. Pressure ulcers, and only in rare circumstances do I find that are pressure ulcers unavoidable. So if the person is moved properly, if they're turned and repositioned, if they're given cushions or wedges if they're in a wheelchair to prevent sitting on one spot for too long, these pressure ulcers can be avoided. Once they start, they can be very difficult to heal. And once they progress to a point where the subcutaneous tissue is exposed and you get down to the bones and the tendons, we have high risk of infection, high risk of sepsis, and it's very, very difficult to cure. So bed sores are something that the nursing homes should be looking to prevent, not allow to happen and then treat.
What recommendation do you have for the son and daughter to be monitoring that? Because obviously, as you said, it's in the back, the lower back. It's not an area you come in and say, "Mom, let me take a look at your buttock area." You know,
that's a good point.
You don't do that. So, what's your recommendation?
That's a very good point. I counsel everyone who comes and speaks to me about a loved one in a nursing home to inspect their body. The nurses' aides and the nurses are supposed to do that. Monitoring the skin is one part of that care plan that's supposed to be done regularly. Oftentimes it's not, and anybody who's visited a nursing home knows, particularly if they've gone there on a Saturday afternoon, you might sit by the nurse's station for 2 hours and not see a soul. So your loved one cannot be getting the care that they need. There's no way anyone's moving their body. So I suggest when they're getting changed, if they're incontinent, take a look, ask to see their body. It can be a very difficult thing to do, particularly for a resident who is still cognitively intact. Kind of tough to ask your parent, can I take a look at your backside?
Yeah.
So it's a difficult thing, but you have to be diligent. If you suspect anything, if your mom says, my back's bothering me, or you see an expression of pain on their face, grimacing when they're moving, that can be a sign that there's something going on back there. And the sooner the better as far as treatment and better outcomes.
And I think the word I'm going to ask. So what does the son do? And I think the word is not remain silent.
You can't remain silent. I like to, one phrase I use all the time is the squeaky wheel is going to get the grease. You have to be very diligent and vocal. Make your presence known. Speak to the administrator. There's no reason you can't ask to speak to the top person, which is the administrator in any facility. Introduce yourself. Tell them that this is my mom. I love her very much. We brought her here because we felt that you could provide the level of care that she needs. We're trusting you to do that. Have that conversation.
Great. I'm going to move. We talked about bed sores. What about falls?
Yes, and falls are a little bit trickier, particularly where you have a resident who is mobile and able to walk on their own. For those residents, fall risks and preventative measures can be a little tougher for the nursing home to implement. If you have the ability, whether it's on your own or with a walker, to walk down the hall and you trip and you fall, it may not be the nursing home's fault that happened. Where we see the most cases are people who are not mobile, who need assistance, either transferring from bed to chair, transferring to a commode, where there aren't enough staff members to handle them and they fall. So we'll see fractured legs, fractured hips, fractured femurs, head injuries. Oftentimes we'll see or we'll hear from a client that the person got a phone call that their mother's being rushed to the hospital because they're complaining of pain in the leg, but they don't know what happened. And when they get to the hospital, they learn that an x-ray reveals a fractured femur. And nobody knows what happened. That is a red flag. If a serious injury like a fracture to any part of the body occurs and no one can explain to you what happened, there's a problem.
What about the issue, and I know we've had a couple of cases where a person twists and turns in bed and winds up, because the sidebars are not up, winds up falling out.
Yeah.
Where does that fit into from a legal perspective?
So one thing nursing homes cannot do is unreasonably restrain a resident. And side rails in hospital beds, those have been a bone of contention for both nursing homes and hospitals for many years. If the resident is a fall risk, meaning that they don't have the motor control to turn in bed and can't control those movements, you have to make sure that those side rails are up. If they're not up, and we've had a number of cases where they should have been up in the evening when the person is in bed, the staff doesn't put them up, they roll out, they fall down to the ground, they injure themselves. Sometimes another big cause of falls is the lack of a proper toileting schedule for the resident. Many residents use the toilet on their own or use a commode. If that's part of their care plan, then when they need to use the commode, oftentimes they'll ring their little bell to get the assistance. Sometimes nobody comes, they decide to do it on their own, and they fall and injure themselves. If they are not cognitively intact and are incontinent and their diaper needs to be changed, oftentimes that won't happen frequently or quickly enough. They'll want to be changed because they're wet. They forget that they don't use the toilet anymore. They get up. Again, it's proper monitoring, proper staffing, the adequate number of people to keep an eye on everybody.
Yeah. What about medication errors?
Yeah, we're seeing a lot more of that, particularly with medications like Coumadin, which is a blood thinner. For those who have heart ailments, who have risk of blood clots, they may be on these medications. A medication like Coumadin, for example, is one that needs to be monitored closely because the therapeutic level of Coumadin is very specific. The range has to be appropriate for that resident in order to for the blood to be either thin enough or not thin enough. And what we're finding with those cases is the blood tests to determine a therapeutic level of the drug in the blood are not done frequently enough. Okay. So you can have on one extreme bleeding, on another extreme you could have a stroke, or even worse. And again, if your mom's on that medication, that's something you really need to be on top of. You need to ask how frequently is the blood test being done to make sure that the level of the drug is therapeutic. Another issue with medication errors, we see oftentimes some residents are simply given medications that they don't need to keep them quiet because there's not enough staff to manage everybody. Yeah. So it's a way of keeping them in check, so to speak, but really it's drugging them. And if you see, for example, a change in the behavior of your mom. She used to be energetic, she used to be talkative, she participated, and now all of a sudden she's lethargic and sleeping all the time. You want to ask some questions. What medications is she being given? Remember, the doctor who comes into the facility has the ability to prescribe medication for a resident. If a resident has issues with sundowning, which is a condition where an elderly person confuses night and day. They're up all night, they're sleeping during the day, which poses a problem for the nursing home staff because staffing is less at night than it is during the day. They don't have enough people to take care of the residents who are sundowning, so they'll prescribe drugs to keep them quiet. That is not allowed.
I see. This sounds kind of crazy for a nursing home, but is there any sexual abuse issues?
There are, and again, that's rising. There are instances not only of resident-on-resident sexual abuse, but unfortunately, we've had even cases of staff members who have sexually abused residents. I've personally handled several of those cases, and again, there are some facilities that mix residents, whether it be male and females or ages. Again, that's something you want to ask when you admit your mom to the facility. How are the residents segregated? Is there any segregation based on age or obviously gender? It's an important question to ask.
Maybe the final question I would say is, and I'd like to hear you really recommend so strongly, and that is observe at the time of introduction to a nursing home your mom's body and make sure that you have a clear picture, I guess, of what any ailments potentially would be. And I think that's important to stress on.
Yeah, I tell people all the time, you need to know, the medical history. Not that you need to be a doctor or a nurse, but you want to be familiar. Does your mom have any skin issues going in? Does she have any medical issues going in that need particular attention? And have the discussion with the staff. Make sure they know who you are. Give them your cell phone number, okay? Tell them what hours you're home, what hours you work. If you work at night, for example, let them know that. Provide alternate phone numbers of people that can be contacted if there's a problem. Don't give them the opportunity to say, we couldn't find you or we called you and no one answered. Let them know that you're there and you're going to be watching.
I was in the legislature in 1970 when the explosion, I remember, on Staten Island of nursing home scandal, and it lived for a decade or more. My question is, and finally, in the time that you've been doing this and are certainly an acknowledged expert in this, is these problems in the nursing home the same? They're getting worse? They're getting better? What perspective do you have about the nursing home industry?
Well, I'm very familiar with the laws and when they were drafted in 1975. Of course, I was in grammar school in 1975, so I can't speak from experience. But I can tell you in the close to 12 years that I'm litigating these cases, I'd like to say I've seen an improvement. I think in some areas there has been improvement. I think that for the most part, the staff members who work at the facilities are dedicated people. They wouldn't be in that career if they didn't care.
Yeah, that's very true.
And be caring of others. What I think is happening, though, is again there's this profit-driven motive back there, and there's an economic benefit to owning a nursing home, and there's an economic benefit in creating a situation where you can profit not only from the operation of the nursing home, but from owning the real estate where the nursing home is located. So I think, unfortunately, profit has taken over, and that the residents are sort of left without anyone really advocating for them in the facility. Each facility is supposed to have someone that's called an ombudsman. That person's name is supposed to be on a wall on a piece of paper, so if you have a complaint, you can call this person. These are volunteers, dedicated people who care about residents in nursing homes, but my experience has been that they don't have much power to affect much change. If you feel that something is going wrong, if you feel that your loved one's been injured, contact your office, contact an attorney, let us ask the questions, because unfortunately, I just see an increase in these cases, not a decrease.
John, I said at the outset that this is not only an extremely important area, but I don't think that there is a person, and I say this very sincerely, that is more qualified, more dedicated, more knowledgeable, and more successful than John Daly has been in the nursing home negligence field. And for that reason, John, appreciate very much you being here.
My pleasure,
Thanks
John.
so much.
Thank you.